आ रही है ना फुल स्क्रीन अब?
हाँ भाई
बस ठीक है।
हेलो हेलो
जी मैडम, आवाज आ रही है मेरी?
जी जी आ रही है। स्टूडेंट्स आ गए?
जी स्टार्ट करें मैडम।
ओके ओके, अस्सलाम वालेकुम डियर स्टूडेंट्स। दिस इज
स्क्रीन फुल कर देगा, स्क्रीन फुल कर दें।
जी फुल है मेरी स्क्रीन।
ठीक है मैडम।
Okay. Today we'll do the tumors of small and large intestine. In the last class, you have done the benign tumors of small and large intestine, and today we will cover the malignant tumors of small and large intestine. So at the end of this lecture, you should know the epidemiology, pathogenesis, morphology, gross microscopic features of different types of cancers of small and large intestine. The most common malignant tumor of the intestine, or basically the large intestine, is adenocarcinoma. So what adenocarcinoma is? It's a malignant tumor of epithelial origin. That is adenocarcinoma. It constitutes 98% of all cancers in the large intestine. Its highest incidence in the West, and it causes 15% of all cancer-related deaths in the USA. Mortality is higher in blacks, and its peak incidence is in 6 to 7 decades. Male to female ratio is 2:1 in rectal cancer, and it is roughly equal in colon cancer. Predisposing factors for the adenocarcinoma of the colon are inflammatory bowel disease, that is the ulcerative colitis most commonly, and polyposis syndrome. You have done polyposis syndrome in the last class, that is familial adenomatous polyposis syndrome and hereditary non-polyposis colon cancer syndrome. So these are the polyposis syndrome you have done in your last class with Dr. Lubna. And these are the two predisposing factors, that is inflammatory bowel disease, ulcerative colitis, and polyposis syndrome. Diet has important role in the risk for the colon cancer. Low content of unabsorbable vegetable fiber, high content of refined carbohydrates, high fat, reduced intake of vitamin A, C, and E, because these are antioxidants. So these are reduced intake is one of the cause for one of the risks for the colon cancer. Whereas aspirin exerts a protective effect against the colon cancer, because aspirin and other NSAIDs inhibit cyclooxygenase 2 inhibitors, which is necessary for the production of prostaglandin E2, which is responsible for the epithelial cell proliferation. So the predisposing factors: unabsorbable vegetable fiber, low content, high content of refined carbohydrates, high fat, reduced intake of vitamins. These are the predisposing factors for the adenocarcinoma of the intestine. Then what reduced fiber do? It leads to the decreased stool bulk and alter the composition of bacteria which are present in the intestine, so that this will lead to the synthesis of oxidative bioproducts of bacterial metabolism, which are harmful to the colonic mucosa, because it is expected. जी वालेकुम सलाम।
जी कर दिया मैसेज बाय प्रिंसिपल से उठा के ना पूरा, और है ना स्क्रीन शेयर भी कर दी थी। हाँ पूरा जी हाँ मैडम, इनके उसमें जूम पे जो चार्टिंग है ना उसमें मैंने पोस्ट कर दिया, और जो पिक्चर थी ना वो लेक्चर स्टार्ट होने से पहले ही है ना वो मैंने उस पर लगा दी थी, शेयर स्क्रीन करके 5 मिनट तक लगा दी थी, फिर मैडम का लेक्चर स्टार्ट कराया। नहीं अभी तक किसी का भी नहीं आया, वो जैनुल्ला ने पढ़ लिया, जो जैनुल्ला है ना उसने ना पढ़ लिया उसकी।
जी मैं कंटिन्यू करूं लेक्चर? हेलो
जी
हेलो, कंटिन्यू करना है लेक्चर? बच्चे हैं?
ठीक
हेलो
ठीक है मैडम तो जी मैडम
स्टूडेंट्स हैं, मुझे कंटिन्यू करना है लेक्चर।
हाँ स्टूडेंट हैं मैडम। 198 है।
ठीक है। Reduced fiber causing the decreased stool bulk, which alter the composition of the intestinal microbiota, which are responsible for the causation of the adenocarcinoma in these patients. Then high fat intake also enhances the hepatic synthesis of cholesterol and bile acids, which can be converted into carcinogens by the intestinal bacteria. When you found colorectal carcinoma in a young person, you should think about the pre-existing ulcerative colitis or one of the polyposis syndromes. That is, I have told you, familial adenomatous polyposis syndrome and hereditary non-polyposis colorectal cancer syndrome. So individuals with this hereditary non-polyposis colorectal syndrome caused by the germline mutations of DNA mismatch repair, these patients are at a high risk of developing the colorectal carcinomas. Regarding the cancer genetics, there are certain genes, number of genes are mutated in the causation of these tumor, and these genes are loss of APC gene, mutation in KRAS, loss of SMATs, which are the cellular proteins that transduce transforming growth factor beta, which is responsible for the inhibition of cell cycle. When there is a mutation in this transforming growth factor beta receptors, so there will be unrestrained proliferation of the cells, and then there will be loss of p53. So these are the accumulated mutations which are present in the colorectal carcinogenesis. Now, there are two distinct pathogenetic pathways for the causation of this cancer. That is, number one is the APC-beta catenin pathway, and number two is the DNA mismatch repair genes pathway. APC-beta catenin pathway, this is the pathway which is accountable for 80% of the sporadic colon tumors. And here in this pathway, there is a classic adenoma carcinoma sequence. Means that, first of all, there will be proliferation of localized colon epithelial cells, which is followed by small adenomas, which become more dysplastic, and ultimately they develop into invasive carcinoma. So first of all, there will be proliferation of the colonic epithelium, which is normal, and it will form the adenomas. Adenomas are the benign tumors of glandular origin. Then they become dysplastic. Dysplasia means when the normal cells are replaced by the cells which have mutations, and they on histology appear as irregular cells with loss of nuclear polarity, nuclear polymorphism, and hyperchromasia. These are the microscopic features of dysplasia. So in APC-beta catenin pathway, there is a sequence. First of all, there will be formation of adenomas. Then this adenomas will progress towards the invasive carcinoma. And what APC is? Basically, APC is a key negative regulator of beta catenin, and this APC normally binds with the beta catenin and degrades it. With the loss of this APC function, beta catenin accumulates and translocates to the nucleus, where it forms the complex with the DNA binding factor and activate the transcription of genes that include MYC and cyclin D1 that promote proliferation. So basically, the APC protein degrade the beta catenin, which is the protein which is responsible for the transcription of genes which are involved in the cell proliferation. So when this APC will be mutated, there will be beta catenin accumulation and transcription of the genes which causes the cell proliferation. So this is the component. So this APC is a negative regulator of beta catenin. So this APC mutation is the early event in the carcinogenesis process of colon cancer. Now this is the diagrammatic representation. That is the normal colon. Normal colon has mucosa, submucosa, muscularis. In normal colon, there is a germline mutation, which is either inherited or acquired mutation of the cancer suppressor gene. This is the first hit. As you know, in your early chapters, that there's a two-hit theory for the cancer formation, first hit and the second hit. First hit may be inherited or it may be acquired. So first hit here in this case is APC, which is at chromosome 5p21. This germline mutation in one of the allele is either inherited or acquired. Then there will be second hit, that is abnormalities or inactivation of the normal allele. So this is the mutations present, and then there is the proto-oncogene mutation KRAS, which causing the proliferating epithelial cells, which will be converted into adenomas. Adenomas are the polypoidal or finger-like projections lined by the epithelial cells. So this is the adenoma, and when further mutations accumulate, that is P53 and many other genes, they will cause the invasive carcinoma. That is, when the basement membrane is breached by the tumor, this is invasive carcinoma. This is the adenoma, which is the protrusion from the mucosa, and it is lined by the epithelial cells, which are proliferating, dysplastic. But when this adenoma invade the muscle layers, that is mucosa, submucosa, muscularis, and it invade into the wall, penetrate deep, it will cause the invasive carcinoma. Then the KRAS mutations and P53 mutation, as I have told you in the previous slide. KRAS mutation promote the growth and prevent apoptosis, and this is the late event in the carcinoma development. And then 70 to 80% of the colon cancers have P53 mutation, which are caused by the chromosomal deletion. So the chromosomal deletions are the hallmark of APC-beta catenin pathway. So these are the mutations which accumulate at a certain stages of time, and then they form a sequence of epithelial proliferation, then adenomas, and then invasive carcinomas. Then mutation in other tumor suppressor genes, like the proteins, like the genes which encode proteins SMAD2 and SMAD4, which are effectors of transforming growth factor beta signaling. As you know, transforming growth factor beta signaling normally inhibits the cell cycle, and it also inhibits the colonic epithelial cell proliferation. So when there is a mutation in transforming growth factor beta receptor, it can contribute to the uncontrolled cell growth. And while the loss of BAX, which is a pro-apoptotic gene, this may also enhance the survival of genetically abnormal clones which have a mutation. So these are the accumulation of the mutation in the causation of colorectal cancers. Then the methylation is another process which causes the silencing of the gene. When this methylation occurs in the CpG-rich zone or CpG island at a 5' region of some genes, that includes promoter and transcriptional site, then they will cause the silencing of the genes. So these genes will be absent, so they will also contribute to the proliferation, uncontrolled proliferation of the cells. Then expression of telomerase. Telomerase is an enzyme which is responsible for the telomere formation and which is necessary for the cells to proliferate. So as the lesion advances, the expression of telomerase also increases. This telomerase expression is increased in many tumors. So this is one of the key factor for the tumor to proliferate. Then second pathway is the DNA mismatch repair genes pathway. This accounts for 10 to 15% of the sporadic cases, and there is accumulation of mutations as in the APC-beta catenin scheme, but the involved genes are different here. So what these genes are? Basically, these genes are MSH2, MSH6, MLH1, PMS1, and PMS2. These are the DNA repair genes, and these will be defective. These will be defective in this pathway, and this is the fundamental and one of the most likely initiating event in the colorectal carcinomas. When there is inherited mutations in one of the 5 genes, they give rise to hereditary non-polyposis colon cancer. And MLH1 gene is the one most commonly involved in the sporadic colon carcinomas. Then hereditary non-polyposis colon cancer syndrome, it accounts for 2 to 4% of colonic cancer. It's an autosomal dominant disorder characterized by familial carcinomas of the colon, affecting predominantly the cecum and the proximal colon. Then these patients, that is with the hereditary non-polyposis colon cancer patient, inherit one mutant gene and one normal allele from their parents. But when the second copy is lost through either through mutation or through epigenetic silencing, defects and mismatch repair lead to the accumulation of mutations at rates up to 1,000 times higher than normal. and which will be mostly in the regions of short repeating sequences referred to as microsatellites, which by chance activate protein oncogenes or inactivate tumor suppressor genes. So this is hereditary non-polyposis colon cancer syndrome. These patients inherited one mutant gene and one normal allele, but when in their lifetime second copy is lost either through any gene silencing, through mutation or epigenetic silencing, these defects in the mismatch repair genes lead to the accumulation of mutations at rates up to 1,000 times higher than normal, mostly in the microsatellite region, mostly in the microsatellites, and which by chance activate the proto-oncogenes and inactivate tumor suppressor genes. So what are the microsatellites? Okay, what are the microsatellites? These are the repeats of 1 to 6 nucleotides found throughout the genome. In the normal people, the length of these microsatellites remains constant, but in people with the HNPCC, these satellites are unstable, either increase or decrease in length in tumor cells, creating the alleles not found in the normal patients. So these can be detected in about 15% of the sporadic colon cancers. So in HNPCC patients, there is a mutation in the microsatellites. And what microsatellites are? These are the short sequences of 1 to 6 nucleotides found throughout the genome, which is their length is normal and constant in the normal people, whereas in the cancer patients, these are unstable, either increase or in decrease. Okay, so microsatellite instability is the molecular signature of defective DNA mismatch repair, as I have told you. So most microsatellite sequences mostly are in the non-coding regions, but sometimes they are located in the coding regions or promoter regions of the genes, which involved in the regulation of cell growth. Now the morphology. Morphology, that is the gross and microscopic appearance. So 60 to 70% of the tumors are in the rectum, rectosigmoid, and the sigmoid colon. And left-sided carcinomas tend to be annular lesions, the encircling lesions with the early symptom of obstructions. And neoplasm starts superficially in the mucosa, then slowly invading the deeper layers like submucosa, muscularis, and with ulceration and eventually metastasis to the distant or near organs. Now, this is the gross appearance of the intestine, which has a tumor, which is polypoidal in configuration. These tumors may be polypoidal, may be fungating, or may be ulcerative. So this is the polypoidal lesion present in the colon. That is the gross examination. That is the naked eye examination. Right-sided carcinomas tend to grow as a polypoidal, fungating masses, and obstruction is uncommon. Invasion of the wall and extend to the mesentery. They invade to the, as I have told you, in the different layers of the colon like submucosa, muscularis, serosa, and extend to the mesentery, regional lymph nodes, and more distant sites. Mucinous adenocarcinomas secrete abundant mucin that may dissect, and small cell undifferentiated carcinomas are rare, that is arising from the neuroendocrine cell. In ulcerative colitis, poorly differentiated infiltrative adenocarcinoma without an exophytic growth. Now this is the microscopic appearance. This is the adenocarcinoma. So what adenocarcinoma? It is a malignant tumor of the epithelial origin, and these are the irregular glands, because adenocarcinoma means glandular tumor. So this is the these are the glands, irregular glands, which are lined by the moderate to mildly pleomorphic and hyperchromatic nuclei. This is the stroma, that is a connective tissue between the glands. This is infiltrated by the inflammatory cells. So this is adenocarcinoma microscopic appearance. Now the clinical features: left-sided lesions tend to present earlier but also have more infiltrative growth pattern and poor prognosis. Right-sided lesions tend to present with weakness, malaise, weight loss, and unexplained anemia secondary to early bleeding. Colorectal carcinoma, its spread is either directly to the nearby organ, distant organ, or metastasis through lymphatics, blood vessels, and favored sites are regional lymph nodes, liver, lungs, and bone. So this is the spread of colorectal carcinoma, and serum levels of carcinoembryonic antigen CEA are related to the tumor size and extent of the tumor extent of spread. They are helpful in monitoring for recurrence of tumor after resection, and overall 5-year survival rate is 35 to 49% in the United States. Other malignant tumors are also there. Beside adenocarcinoma, there are malignant tumor which are mesenchymal in origin and lymphoid tissue origin. So malignant spindle cell lesion, that is the mesenchymal lesions, are also there, which are the stromal tumors. And lymphomas are also there, which are the lymphoid tumors arising from the lymphoid tissue. Grossly and microscopically, these resembles those arising anywhere in the GIT. Carcinoid tumor is one of the tumor that may arise from the endocrine cells, and they may arise anywhere in the colon, especially the rectum. Squamous cell carcinomas are largely limited to the rectal canal and anal canal, rectal canal and anal. NS initially present as a plaque-like lesions, later becoming ulcerated or fungating. And malignant melanoma is also there at the anal word. So these are the different malignant tumors of the most common that is accounting for 80% is adenocarcinoma. But other mesenchymal tumor like GIST, gastrointestinal stromal tumors, and the lymphomas are also present. Carcinoid tumors may also present here. Squamous cell carcinoma and malignant melanoma. These are also the malignant tumors which may present in the colon. You should know the names of these, and adenocarcinoma in detail, their pathogenesis, their clinical features. These are important for these tumors. Now the summary, familial adenomatous polyposis and hereditary non-polyposis colon cancer are the most common forms of familial colon cancer. It is caused by APC mutation. And patients in this familial adenomatous, patients have more than 100 adenomas and develop colon cancer before the age of 30 years. And whereas HNPCC caused by the mutation in the DNA mismatch repair enzymes, these patients have far fewer polyps than FAP and develop cancer at older ages. And these both syndromes typify distinct pathways, neoplastic formation and progression towards the carcinoma. And these also contribute to the majority of sporadic colon cancers. The sporadic cancers are cancers that are not hereditary. And nearly all colonic cancers are, that is around 80 to 85% are adenocarcinomas. The two most important prognostic factors for the adenocarcinomas are the depth of invasion and the presence or absence of the lymph node metastasis. So this is about all adenocarcinomas. Now the small intestinal neoplasm. Up till now we have done with the tumors of the large intestine, now the small intestine. This is 3 to 6% of the GIT neoplasm, slight preponderance to the benign tumors. But there are malignant tumors, but commonly the benign tumors are most commonly found here, that discovered incidentally, that is leiomyoma, adenoma, and lipoma. And the large lesions, although they are benign, but the large lesions may cause obstruction, bleeding, intussusception, and volvulus. So what leiomyoma is? Leiomyoma is a benign tumor of smooth muscle origin. So it may arise in the wall of the colon. Then adenoma, we have discussed, it is a polypoidal, finger-like projection of glandular epithelium. And lipoma, it's a benign tumor of fat, fibroid adipose tissue. So these are the benign tumor which may present incidentally in the small intestine. Adenomas, we have done that, it may be single, it may be multiple, most often in the duodenum and ileum, and there is a risk of malignancy with the larger adenomatous polyp. And the malignant tumors here in the small intestine in descending order of frequency are carcinoid, adenocarcinomas, lymphomas, and leiomyosarcomas. Leiomyosarcomas are the malignant counterpart of the leiomyoma. That is, we have discussed, that is the tumor, leiomyoma is the benign tumor of smooth muscle origin, and leiomyosarcoma is the malignant tumor of the smooth muscle origin. So these are the tumors of small intestine. Tumors of the small intestine of adenocarcinoma, it grow as a polypoidal fungating ulcerating mass or encircling pattern. Site is mostly the ampulla of Vater in the duodenum, and presentation will be with the abdominal cramping, pain, vomiting, and weight loss. 5-year survival rate is 70% after en bloc resection. This is adenocarcinoma of the small intestine. Then the carcinoid tumors. So what carcinoid tumors are? These are the tumors or neoplasms that arise from the endocrine cells or the enterochromaffin cells found along the length of the GIT. These cells have an affinity for the silver stain for the identification, and 60 to 80% of the appendix and terminal ileum. These carcinoid tumors are present in appendix in 60 to 80% of the cases, in 10 to 20% in the rectum, the remainder in the stomach, duodenum, or esophagus. Other locations where carcinoid may present: lungs, pancreas, biliary tract, ovaries, and liver, because all these places have endocrine cells. Peak age for these tumors is in 6 decades, comprising of 2% of the colorectal carcinomas and 50% of the small intestinal carcinoma. So it is common in small intestine compared to the large intestine. Tumors in the appendix and rectum, although spreading locally, but they seldom metastasize. Ileal, gastric, and colonic carcinoids are frequently malignant. Now, this is the morphology, how these cells will look like on an H&E stain, which is a routine stain of the histopathology. So these are the microscopic pictures which are round. So first of all, we'll discuss about the gross appearance, that is the round submucosal elevations that are bright yellow to yellow gray, maybe deeply infiltrative to the muscle and to the serosa. This is the polypoidal lesion. Okay, and these cells are monotonous cells. They have round regular nuclei, and they are arranged in different configurations like trabecular, insular, and glandular. And this is the ultra electron microscopic picture, that is the neurosecretory electron dense bodies in the cytoplasm. So this is the ultrastructure. This is the microscopic picture, polypoidal tumor with the yellow, bright yellow gray appearance. This is the microscopic monotonous cells with regular round nuclei arranged in sheaths, trabeculae, insular, and glandular pattern. Then clinical features, it may cause obstruction, intussusception, or bleeding. It may elaborate hormones, that's why causing Zollinger-Ellison syndrome, Cushing syndrome, or other syndromes. 5-year survival rate for the carcinoid tumor is 90%, and small bowel carcinoid with liver mets, the 5-year survival rate is better than 50%. Carcinoid syndrome occur in 1% of all patients with carcinoid and in 20% of those of the widespread metastasis. The symptoms are paroxysmal flushing, episodes of asthma like wheezing, right-sided heart failure, attacks of watery diarrhea. This is the carcinoid syndrome. Abdominal pain, edema, and pellagra-like lesions of the skin and oral mucosa. The principal chemical mediator of these neoplasms is serotonin, which is decarboxylated in the liver and lungs to hydroxyindoleacetic acid. The syndrome is classically associated with the ileal carcinoids with the hepatic. This syndrome, which has paroxysmal flushing, asthma-like wheezing, right-sided failure, this is usually associated with the ileal carcinoids with the hepatic mets. Now the lymphoma is the malignant tumor origin from the lymphoid tissue, and up to 40% of the lymphoma arises in sites other than lymph nodes. Gut is the most common site, and 1 to 4% of all gastrointestinal malignancies are lymphomas. Primary GI lymphomas exhibit no evidence of liver, spleen, or bone marrow involvement at the type of diagnosis. Lymphomas have the different subtypes, but most commonly here, the lymphoma arise from the B cells of the mucosa-associated lymphoid tissue, that is the maltoma or mucosa-associated lymphoid tissue. This usually affects adults, lacks a sex predilection, and may arise anywhere in the gut. In stomach, it is 55 to 60%. In small intestine, it is 25 to 30%. Proximal colon, 10 to 15%, and distal colon up to 10%. So this is lymphoma arising from the B cells of mucosa-associated lymphoid tissue. Gastric maltomas arise in the setting of mucoid lymphoid activation, and this lymphoid activation is a result of Helicobacter associated chronic gastritis. That's why it is common in stomach, because it is related with the Helicobacter pylori associated infection, because this infection causing the lymphoid activation. And second, celiac disease is associated with higher than normal risk of T cell lymphoma. So gastric B cell lymphoma in the stomach due to the H. pylori chronic gastritis or H. pylori associated chronic Helicobacter associated chronic gastritis, and celiac disease is associated with the higher than normal risk of T cell lymphomas. Primary GI lymphomas have a better prognosis than do arising in other sites. Treatment is combined surgery, chemotherapy, and radiation therapy. Okay. Now, if you have any questions, please, you can ask. Hello? Hello? Tariq? लेक्चर तो फिनिश हो गया. अब ये स्टूडेंट्स के कोई अगर सवाल हैं तो वो कैसे पता चलेंगे? B cell lymphoma arise, as I have told you. Okay, I will tell you. Okay, somebody has asked question, ma'am, how arise from B cells Hodgkin or non-Hodgkin lymphoma? As I have told you that lymphoma arise from the B cells which are present in the mucosa of the mucosa-associated lymphoid tissue in the gut. So these are the non-Hodgkin lymphomas, not the Hodgkin lymphomas. B cell lymphomas arise from the mucosa-associated lymphoid tissue, mostly in the setting of HB infection, and T cell lymphoma arise in the setting of T cell, I mean in the setting of celiac disease, because it will cause the T cell activation, as I have told you in the lecture of celiac disease. Any other question? तारिक फिर चला गया ये.
मैडम आ रही है आवाज आपकी?
आ रही है मेरी, लेकिन मुझे क्वेश्चन नहीं नजर आ रहे
बच्चों
का. क्वेश्चन
मैडम ये चैटिंग पे आएंगे. आप है ना मोर में जा, मोर है ना नीचे देखें, मोर का ऑप्शन आ रहा है, उसको खोलें.
एक मिनट, कौन सा है मोर का अक्षर? वो कौन सा है कह रहे हैं?
नीचे 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 टास्क बार में मोर का.
टास्क बार में कह रहे हैं मोहर कौन सा आ रहा है?
मोर का ऑप्शन होगा, उसके अंदर जाके चैटिंग खोलेंगे आप.
चैटिंग खोल तो लिए, लेकिन ये एक ही सवाल है जिसका मैंने आंसर
आएंगे
कर
कुछ.
दिया है.
हाँ बस फिर स्टूडेंट ने नहीं करे, और स्टूडेंट ने नहीं किया मैडम.
और ने नहीं किया. ओके ओके, थोड़ा सा वेट कर लेते हैं फिर.
जी 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 जी, कोई मसला नहीं मैडम.
5 मिनट्स है, अगर कोई करता है तो फिर कर लेते हैं.
देखिए मैडम, मैंने एक है ना एक लिंक शेयर किया आ रहा है, आपके पास आ रहा है
लिंक?
ये मैसेज जो स्टूडेंट के ने किया है?
जोहरा ने जो किया हुआ है, इट इज मैंडेटरी फॉर
जी
एवरी
जी जी।
स्टूडेंट टू फिल दिस सर्वे फॉर्म ऑन एन अर्जेंट बेसिस
हाँ
लेटेस्ट
थोड़ा
बाय
सा है ना, आप बोल देगा ये।
क्या बोल दूं मैं?
नहीं नहीं, बस वो मैंने भेज दिया, बस आपके पास आ गया तो स्टूडेंट के पास सबके पास आ रहा है।
ओके ओके। तो ये जो आएगा फॉर्म, ये मेरे पास तो नहीं आएगा, ये आप ही लोगों के पास आएगा शायद।
जी 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 जी।
ओके